Good evening, everyone. My name's Tim Coates. I'm Professor of Emergency Medicine at the University of Leicester, and I chair trauma care. We have to say a big thank you to our sponsors, Slater and Gordon. Without their sponsorship, this wouldn't be happening, and we're grateful to them. There is a disclaimer that we have to give in that we'll talk about lots of things in the trauma care webinars that are, stuff in the future, stuff that we're just ideas that we're knocking around. Just because we talk about something doesn't mean that you can go and do it in your clinical practice. It's really important that you stick to your own organization's guidelines when you're treating patients. You can become a trauma care member. It's really cheap, £8 a month if you're working. If you're not working, non-registered or students, £3 a month. So I think we'll just move on to introduce our speaker for this evening, because he's who you've come to hear, not me. Professor Gavin Perkins from the University of Warwick, who is current chair of the Resuscitation Council UK and is going to be talking to us about the future of resuscitation. Gavin, over to you.
Great. No, thanks, Tim, for the kind introduction, and how fantastic to have so many people from around the world at today's webinar. So, thank you everyone for taking the time to join us. So, as Tim has said, I'm going to focus on a forward-facing vision, Resuscitation 2050, and what the future might hold. I'd ask you to consider what I discuss in the context of the conflicts of interest that I've summarised here. What I'd say is that the views in the talk represent my views rather than any of the organisations or grant funders that I have the pleasure of being associated with. So without further ado, let's move forward to start to think back to the early stages of CPR and the chain of survival, which was first conceived back in the 1990s. The concept behind the chain of survival is that there were key links in the resuscitation sequence that are required in a sequential order in order to optimize and improve outcomes. And as of the concept of a chain, that a chain is only as strong as its weakest link. So if you don't have a strong chain from start to finish, that you're not going to optimize and improve survival to its greatest potential. At the top is the first chain that was widely circulated, which focuses on early identification of cardiac arrest, early CPR, early defibrillation and early advanced care. The red ones here are the American Heart Association, which has progressively added links to the chain of survival. In Europe, we've tended to stick to 4 links in the chain of survival. And for the last 15-20 years, early recognition and call for help, early CPR, early defibrillation and post-resuscitation care. And then in 2025, consolidating some of those earlier rings and bringing in survival and recovery. We've also seen changes in emphasis of the chain of survival. And this was from Charles Deakin, representing really that the key place where you're going to have the biggest bang for your buck is in the early recognition and call for help in the early CPR phases. And I think as we come on to the bulk of my talk, then I will be very much focusing on that early phase, because absolutely early recognition and call for help are the bits that are going to really make a difference in cardiac arrest. So we've had 40, 50 years of resuscitation, the chain of survival around for 30 or 40 years. And let's think what impact that has potentially had. So these are data from the Swedish cardiac arrest registry for out of hospital cardiac arrest on the left, and you can hopefully see some early progress in improvement from out of hospital cardiac arrest as guidelines became more standardized, as systems worked together to implement the chain of survival, that we saw progressive increases in survival from 2000 through to about 2010. But things seem to have plateaued there, and a similar type of pattern for in-hospital cardiac arrest. If we look in the UK context, we haven't got 25 years worth of data similar to Sweden. For out of hospital cardiac arrest, we've seen incremental improvement, but no substantial step change in survival from either in or out of hospital cardiac arrest. And I think it's that really that puts us into the place that we need to start thinking about things differently. And I think the key enablers for improving outcomes over the course of the next 20 years are going to be based on the 4 or 5 key elements here. Firstly, data integration. At the moment, we've got a lot of information and systems that sit out there in health systems around the world, often disconnected from each other. So the opportunities of bringing data together and integrating those into a single care record that provides a comprehensive summary of an individual's risk of cardiac arrest and their likely personalised response is going to be key. We're hearing almost every day about the impact of artificial intelligence, and I think it will similarly have a big impact in the future. I don't think, as we were hearing today in the UK about artificial intelligence and its impact on jobs, I think that there's still in resuscitation and in medicine absolutely going to be a central role for the human part of resuscitation. I think when we have those two, data integration and artificial intelligence, then it will allow us to apply the principles of personalised treatments. So rather than taking a one-size-fits-all, that we can actually tailor the right treatments to the right individuals at the right time. And of course, all of this is only going to work if you can pull together a system that enables these technologies to be pulled together in order to optimise outcomes. And then as a cross-cutting theme at the bottom there, I have research and evaluation, because as many wise people before me have said, that you can't have innovation without evaluation, because untested innovation leads to uncertain effects, and evaluation and research are going to be absolutely key in demonstrating which are the best modalities to take forward and what their impacts on health are going to be. So let's start to think in terms of the challenge that is faced here and now. And a major challenge that we face in cardiac arrest is the unwitnessed cardiac arrest. This is a slide which took data from the Canadian Cardiac Arrest Registry. It includes treated and untreated out-of-hospital cardiac arrests attended by emergency services in Canada. And what it's done is it's looked at the proportion of patients that sustained an unwitnessed versus a witnessed cardiac arrest, and then looks at the impact that it has on bystander CPR, defibrillation, and survival. And what you can hopefully note from this, or I think the key things to pull from this, is that the majority of cardiac arrests, 77%, are unwitnessed. Being unwitnessed means that you're less likely to receive bystander CPR and you're less likely to receive bystander defibrillation. And the overall survival rate for unwitnessed cardiac arrest is only 2%. If you contrast that with witnessed cardiac arrest, then actually in that context, survival rates are much greater. So I'd ask you to just hold that significant opportunity in converting unwitnessed cardiac arrests over to witnessed cardiac arrest, and some of the technological opportunities that may come along in order to enhance that. So this is a slightly enhanced version of the previous slide of the unwitnessed cardiac arrest, and I'll just use it to illustrate how that unwitnessed cardiac arrest can be turned into the witnessed cardiac arrest. So if we start by thinking about wearable devices, and in this slide it was the wearing of a watch, that actually the technology exists now in order to detect cardiac arrest, and there are a number of research groups around the world looking at taking the concept of a wearable through to a system that can actually be used to detect and report a cardiac arrest. And the broad principles of those systems, and the DETECT study group have been really leading the way here, are the watch's ability to monitor an ECG and also to look at the plethysmography trace, so kind of the pulse waveform that happens with each heartbeat. And in this original series of experiments, they were testing people that were undergoing expected cardiac arrest because they were having some form of cardiac surgery or other, and looking at the device's ability to detect cardiac arrest. And as you can hopefully see in these experimental and tightly controlled conditions, the devices were really quite sensitive at detecting cardiac arrest and relatively specific. If you take that a step forward, then you can imagine adding those signals with the signals that come from the accelerometer that exists in many smartphones, also exist in watches. And there are characteristic patterns that are detected on an accelerometer as you go from a standing position and you fall to a lying position. And again, further work done by the DETECT group was integrating the watch-based signals along with fall-based signals. So they had a group of volunteers, they kitted them up with the equipment, and they said, go out and simulate a cardiac arrest. So they would simulate the cardiac arrest by blowing up a blood pressure cuff on their arm and then throwing themselves onto the floor, and were able to demonstrate in a large series of these experiments that the watchers were really quite good at detecting the signs of a cardiac arrest. And we've now, a relatively short time ago, had the first case of a cardiac arrest detected with one of these wearable devices. It was actually being used as part of one of the studies when someone was out cycling and they came off their bicycle. They were known to have a heart condition. They already had an internal defibrillator, so the watch-based system was able to demonstrate the changes in the plethysmography, in the ECG, the person falling off their bike, and detect the cardiac arrest. So this technology is ready, or this technology has reached the point that it's ready to go out for real-world evaluation. And in fact, some of you may have seen this, that Google, although to my knowledge, none of these systems consistently link with an emergency services, but the Google simulation watch will do what we're talking about. So no pulse is detected. It then calls the emergency service. It plays a pre-recorded message telling you the location of the cardiac arrest. It tells you the fact that the person has sustained a cardiac arrest, and is able to send any health details that the person has saved in their telephone. You have the option of aborting that at any point during the process. Okay, so that's the watch-based approach to detection. This is a slide where I brought some video that was provided to me with consent from somebody demonstrating agonal breathing that had been rescued from the water. And it's there to illustrate the characteristic pattern of agonal breathing, which is slow, irregular, often ineffective respirations. And this is something that is often a distractor for people detecting a cardiac arrest, but actually technology can help with this. And things like an Amazon speaker or Alexa speaker or Apple speaker are often constantly listening for you to give them an instruction. And that constant listening means that it's constantly receiving noise and information. And if you analyze the information that's coming in, as the group did here, using a spectrogram which combines frequency and power, that you can actually use these devices to detect agonal breathing, because there's a characteristic pattern of agonal breathing that trained people can recognize, but you can also train the speaker through an AI system to be able to do that. And more importantly, through this series of recordings that we use to test it, it can tell the difference between agonal breathing, slow breathing, central apnea, and also obstructive sleep apnea. So the speaker potentially sensing that you have sustained a cardiac arrest, either to reinforce or to prompt the watch to undertake an evaluation. There's then things like CCTV cameras or ring type cameras, which are also used in the household, and those are able to detect, and or at least there's proof of concept that an AI system can detect when somebody has fallen and when they're motionless on the floor. So again, another way with high sensitivity of identifying that someone has sustained a cardiac arrest. So if you imagine a future state where you've integrated all of these technologies together, then actually you're moving from the position where the unwitnessed cardiac arrest that was our biggest challenge actually is no longer a challenge, because we have the technologies when someone is not there in order to detect the cardiac arrest. And this modelling then just shows the potential impact on the system. And there are two components here. This is how sensitive, so how good the system is at detecting the cardiac arrest, and then this is how widely the technology was implemented. And what you can hopefully see is that the survival rates go up as you increase the sensitivity and you increase the implementation of the technology, and you're increasing the survival by I think it's 2.6 times greater survival. So the unwitnessed cardiac arrest potentially becoming something of the past. Moving on then to think about the other ways in which artificial intelligence can assist the emergency responses. The literature is literally littered with barriers to emergency call handlers being able to effectively identify a cardiac arrest. It may be agonal breathing, there may be language difficulties, there may simply be things about the tone and the way in which people convey information that actually all aid the diagnosis of cardiac arrest. And so I think in a future state, there's been one randomized controlled trial that demonstrated proof of concept that the system could be deployed, but it didn't improve cardiac arrest recognition. But as the models get better, as they're trained more, then the concept that the emergency dispatcher will have prompts or will have alerts to identify that there's a high probability that someone has sustained a cardiac arrest. So the 25 to 35% of cardiac arrests that are missed in the current call sequence potentially again become something of the past. The recent scoping review presented here in 2025 describes further areas where artificial intelligence may help with the response to cardiac arrest, so that there's evidence of its utility to improve CPR quality, to provide real-time feedback, and also to assist with training. There's also data that demonstrates that artificial intelligence models can assist with both the forecasting the likelihood of a cardiac arrest, but also working out optimal routing, prioritizing dispatch, and enhancing communication. So this was a study that was done in India, known very well for the congestion that they face, and so having something that can cut its way through that in order to identify the optimal response. So this kind of summarizes the first bit, which is converting the unwitnessed cardiac arrest into a witnessed cardiac arrest, and then the role of artificial intelligence for enhancing the emergency response. So we've got detection, emergency call, AI support for the emergency operator, and then an enhanced support for response, sending the nearest and fastest response, potentially using technologies such as drones with AEDs, and the potential utility of those devices to support the quality of resuscitation. But before those components are potentially, challenged, that it would be absolutely great. It would be transformative to improve survival from 5 or 6% to 15%. But it's that's moving things forward. It's not transformative, and I think the transformative bit is we need to get to a position where at the moment 90% of people die from cardiac arrest, only 10% survive. So survival is unlikely. We need to invert the pyramid and move to a situation where survival becomes the norm and the expectation. And I think in order to do that, we need to go beyond simply converting unwitnessed to witnessed cardiac arrest. And that's why I think cardiac arrest prevention is going to play a key role, because what better way to improve population outcomes from cardiac arrest than preventing the cardiac arrest from happening in the first place. So this was, as a concept, has been really nicely summarised by Kolk and colleagues in Heart Rhythm, where they describe that a large population, the challenge that we have is that there's a large population who have a very low risk of cardiac arrest, where it's challenging to undertake a high level of risk stratification, through to smaller subgroups where the risk of cardiac arrest is greater, looking at the top there. So if you have an impaired cardiac ejection fraction and ischemic substrate, then you'll have a much higher probability of cardiac arrest, but you're a much smaller part of the population as a whole. So they developed the concept that one is able to undertake a sequential risk stratification, so that you could potentially do population level screening at a simple level with family history, ECG, maybe clinical variables. For people that are then at higher risk, you undertake further tests such as echocardiography, contrast MRI, and potentially then on to electrophysiological studies, so that you sequentially hone in onto the populations at greater risk. So let's look at the concept of screening electronic health records. So this was data done in the States, where they took a whole health system's health records, and they combined that with the sudden cardiac arrest database or records, and said, what are the features of 12,000 people that sustained a cardiac arrest and 12,000 people who didn't sustain a cardiac arrest? What is it in their medical records that would enable us to distinguish and to identify the patients that are going to go on to have a cardiac arrest? And they did it in a robust way with an initial derivation cohort for their AI model, and then they retested that in a separate part of the database. They also took control for geographical and variation over time. And what was fascinating, they were able to demonstrate that that up to 5 years prior to a cardiac arrest, there was evidence in the electronic health record that placed people at a higher risk of sustaining a cardiac arrest, and that they were actually able to detect between a quarter and a third of all cardiac arrests that were going to happen simply on the basis of surveillance or looking into the electronic health records with an artificial intelligence system. So if you imagine that might be the first stage of population risk stratification, people that are then in a higher risk category could then go on to have further tests. And the ECG is often used as a screening test, but the richness of the information in the ECG is rarely extracted from it, because there are the things that we're used to looking at, so the shape and size of the ECG, the so-called ECG morphology, and there are various different measures of those that individually are predictive of the likelihood of cardiac arrest. There's also the variability in heart rate as a predictor of cardiac arrest, so an ECG over a period of time, and then looking at changes over a series of time. And then these, of course, are the patterns that we know about at the moment. But if you apply a deep learning system, that the patterns that are within an ECG that we're yet to work out and identify are potentially pulled out and can perform as part of this predictive model. And these there have been a series of epidemiological studies that have demonstrated an area under the receiver operating curve of between 0.5 and 0.95 for this sort of technology to predict the likelihood of a cardiac arrest. So imagine electronic health records, people at higher risk ECG. You then move into the more invasive, or at least the more resource intensive tests, such as late gadolinium enhancement MRI, cine cardiovascular MRI, and echocardiography, where you can extract further features. You can look at the spatial features, you can look at the textual and intensity of the images that were obtained. You've also got information on the 3D geometry and shape and things that we haven't yet, again, worked out that actually exist within these images and could be a predictor for cardiac arrest. So in these models, again, fairly impressive area under the operating curve of between 0.7 and 0.88. So I guess people would typically describe those elements as the phenotype, so kind of the person elements, but then there are also the genetic predispositions that are widely recognised. And in the earlier years, then these genetic predispositions often lead to arrhythmias or cardio channelopathies that will lead to a cardiac arrest. And then as you get older, then the likelihood that coronary artery disease is the main driver. But all of these things have genetic risk factors that, if one's undertaking genome-wide sequencing at a population level, that you could imagine that that's then integrated with the other information, so that you bring together a rich model for cardiac arrest prediction. There's then a number of environmental factors that also influence the likelihood that you'll sustain a cardiac arrest on a particular day at a particular time. And this is just one of the several examples of environmental factors that can influence the likelihood of cardiac arrest. Air quality is another. This one is focusing in on the impact of weather. And again, it matches weather forecasts with close to 500,000 cardiac arrests that were recorded in the CARES database, and says what are the weather features that predicted, or the weather features that were associated with cardiac arrest. So one can take the information about the person, the phenotypical information, the genetic information, and then you can start to look at environmental risk factors. And you put all of this together, then you're starting to build a dynamic cardiac arrest prediction model for the future, which will contain potentially the elements described: electronic health records, advanced imaging, ECGs, to combine that with genetic risk and environmental factors to undertake a dynamic risk prediction. And given that I'd highlighted that one of the studies could predict a cardiac arrest risk 5 years ahead of the cardiac arrest occurring, then one could imagine a future state that there might be an alert for a routine referral to a cardiologist if your cardiac arrest is 5 years away. But if the cardiac arrest is in the next 24 hours, then maybe you need an urgent referral. And if the cardiac arrest is going to be in the next few minutes, then dispatching the emergency ambulance, having predicted that that cardiac arrest is going to occur. So taken together, I think that will be key to turning the dial for improving outcomes from cardiac arrest. So I wondered, Tim, if you wanted to for me to carry on with the next phase of the talk, which moves to the later bits of the chain of survival, whether any questions had come in that you wanted to.
Yeah, I think it might be an idea just to perhaps go through a couple of questions. The first one is around the survival chart that you showed in one of your first slides, that there seemed to be a big change in survival from cardiac arrest before the sort of chain of survival concept came in. And just wonder what was happening right at the beginning of that chart.
So I think that was probably the Swedish chart, because the UK data, which was the second chart, and I think it's difficult to to know, because we're going back 25 30 years, but I suspect that it's less precision in those data, because events may have been recorded less frequently. I think one of the other big paradoxes that challenges us all in cardiac arrest is that the more people that you resuscitate, that will include groups of people that might never have had resuscitation in
Mm.
the past, and those people often have poorer prognostic factors potentially associated with them. So as you expand the pool of people that receive resuscitation, then you may paradoxically see a decline, because, of course, when resuscitation was first described, it was described for hearts too good to die, and it was very
Yeah.
much the person out running that has the collapse, or somebody that's undergoing an operative procedure and has a resuscitation attempt. And now, if you think how much we've opened up the life-saving opportunities of CPR and defibrillation, we've not got that enriched cohort that have the hearts too good to die. Does that make sense?
Yeah, no, I think that's really interesting. Um, So the technologies that you're talking about that sort of do the surveillance on people, whether it's on whether it's a wearable, camera, listening, is there any work going on about whether that's actually acceptable to patients to have a sort of big brother continually monitoring to look at you, and the sort of privacy aspects of having your health sort of continuously monitored by a sort of rather remote AI black box.
Yeah, no, I mean, I think that is a really pertinent question, Tim, and I've got a slide later which touches on some of those
Mm.
elements, but I think I'll just answer that that particular part of it now. It is that I think firstly that technology is out there in some settings. So my father a couple of nights ago had a fall. He was wearing one of these detectable devices that the council have installed in his house, and the call handler detected that he'd had a call and called him back. And when he didn't answer, they sent someone around and they phoned us up. So we were able to go around and assist him. Now that was his choice. He's chosen to have that monitoring technology in his house, and thank the Lord that he did, because it was 4 o'clock in the morning and we weren't planning on visiting them. But in other contexts, and I guess mental health settings are potentially a good exemplar, where there is a genuine risk of self-harm and high risk events that happen in mental health settings, where there are detection systems that can survey and observe in order to keep people safe. But the acceptability of those systems in the context that you have a mental health condition and that you've potentially been hospitalized as a consequence, that in many situations that's not acceptable to the people when there are. So I think there is a huge piece that needs to be done around understanding public expectation. I think we need to be truthful with people about the potential, and the opportunities, but that there also needs to be a degree of choice. But I think that the trust bit is key, because I think the bit about watching, if it was genuinely for your health and it was protected and nobody could see it, that's a different scenario. If you have that trust from someone might use your data for other purposes that you don't know, and that's where I think things become more challenging. But those debates need to happen.
Yeah. I guess the implementation science here is going to be as important as the technology and development science. Yeah.
Yeah, no, absolutely.
Yeah. Um, More questions coming through, but shall we move on to the second part of your talk,
Yeah,
and
yeah.
then
So
then we'll
we'll
sort
move
of
on, and
wrap the other questions up.
I'm mindful of
Keep the questions coming.
yeah. Now I'm mindful of time as well. So I think it was my intention that the next bits of the talk would move through with more of a pace because I think the real opportunities are in the bits that I've presented. But I think this is to start to think about some of the future opportunities in the resuscitation phase, because at the moment we're often blind in the way that we're delivering resuscitation. We don't have many markers to be able to actually assess and particularly to integrate the information to know whether the resuscitation efforts are optimal or whether there are other things that we can do. And I think this is to bring forward the concept that actually at the moment there's a number of monomodal approaches that are used for assessing the adequacy of CPR. So that can include hemodynamic directed resuscitation, microcirculation, end tidal CO2, and lactate as potential biomarkers. If we move to a future state where you bring all of that together and that's integrated into a artificial intelligence system, that it's able to combine that information and to guide you in relation to the adequacy of your CPR. And we're starting to move into the personalised medicine component now, that it may guide you. This person would benefit at this time from some vasopressors. This person would benefit from higher quality CPR. This person might benefit from hyperventilation. So I think that there's opportunities in monitoring. And this is to just say, as an example, this is from Sam Pioneer and colleagues in New York, that as a proof of concept that they're already starting to use some of this technology. So they start with manual CPR, then deploy mechanical CPR, undertake invasive monitoring, and link alongside that EEG and RSO2 monitoring as a way of working out the stage at which one would move from standard CPR over to eCPR. The recent Wolf Creek paper from 2024 looked at the opportunities for physiology guided CPR and came up with a number of knowledge gaps. Again, I think emphasising that as concepts, they're great concepts, but there's research and evaluation that we need to do in order to correctly configure the system so that we gain optimal benefit from them in the future. This is a VF waveform. I'm sure many will recognise it. And whilst originally described as random and chaotic, time has taught us that it's not random and chaotic, that there's actually information that can be extracted from the VF waveform in order to identify the optimal time for defibrillation. And if one can imagine a future state, and this was a conceptual piece, that one would actually receive real-time feedback on the VF waveform, giving you an indication as to when the optimal time to defibrillate is, or whether actually you should continue doing CPR because there's a low chance of defibrillation success. So the concept that you're receiving physiological signals and that they then tailor your CPR are starting to emerge. Everybody's had lots of fun with dual sequential defibrillation, and people have had even more fun about debating whether it works or not, and whether changing the vector. And I guess the concept is, when you're undertaking defibrillation, that you're trying to position the electrical current to go through the heart, which will be variable in people's chests, and to make sure that it hits the substrate or the point that is causing the ventricular fibrillation. And this paper shows the potential utility of combining information like transthoracic impedance, the defibrillator waveform, and the VF waveform, so that you're actually able to optimize the time and location of the defibrillation attempt. So imagine a scenario, and this as a concept exists at the current time, but it's the future ECG. So rather than having a 12-lead ECG, this is the 256-lead ECG vest that is put on, and rather than just giving you the ECG waveform, it allows you to create an isochrome map of the heart. And so if there was an area that was the focus of the ventricular fibrillation, that you would potentially be able to localize where that stimulus is coming from, so that you can target the defibrillation energy to make sure that the optimal current is used from the optimal direction. And this is just the concept here, that if you imagine that the location of the VF driver is located, it then identifies the optimal energy and then charges the appropriate pads, and then goes to deliver the appropriate shock to the person, so the return of spontaneous circulation is almost guaranteed. Moving then from I guess the ECG bit, that is that there is the question of the transition to extracorporeal resuscitation and the optimal timing for that. And one could potentially imagine that some of the multimodal channels that we were describing before could actually detect the bit at which resuscitation is failing, and to suggest that you go from standard resuscitation onto extracorporeal resuscitation. I'm not going to spend a lot of time talking about the sort of the peri or post-resuscitation care phase, but this is to just flag the concept that when traditional resuscitation methods are failing, that this was the ILCOR statement on post-cardiac arrest brain injury, and that was bringing forward the idea about a post-resuscitation brain injury cocktail of various medications that will impact through the different phases of the ischemia reperfusion type of process. You could imagine a tailored drug being administered. This is the concept then that the post-resuscitation care phase in 2050 will be very different. We've already seen many of these technologies emerging, so it's now commonplace in some countries for a CT scan to be deployed. It's often used for people with suspected stroke. So advanced diagnostic imaging arriving with eCPR capability alongside it, so that not only can you move to the extracorporeal phase of treatment, that you can actually identify what the likely cause is. You can work out what stage of post-resuscitation brain injury the person is in, so that you can give tailored treatments in order to mitigate the risks of post-cardiac arrest brain injury. And again, sticking to the European Resuscitation Council's 4 components now, and to not forget the post-cardiac arrest rehabilitation and the role that technology can potentially play or will play in the rehabilitation of cardiac arrest survivors in the future. So I've already touched a little bit on this, because I think the concepts, I think the data is already pushing us to seeing that these things have a real opportunity to make a difference in the future. But Tim, as you said, the key challenge is actually in the implementation and the studying of the implementation, because there are huge questions and challenges that, alongside the programme of technological developments, there needs to be the programme of qualitative, quantitative and implementation research to assess the acceptability and the barriers and facilitators of making the best of these technologies. And then my penultimate slide is to just bring us back to the patient. And I think, again, it chimes with your earlier question about what if this isn't acceptable to somebody. Well, if the monitoring is not acceptable, so resuscitation is not going to be acceptable, because death is an inevitable part of life and it will affect all of us at some point. And people will have different values in relation to the quality compared to the quantity of life, and those will be different from person to person. The role of artificial intelligence can help potentially in that decision-making process by helping to inform the shared decision-making conversation, by helping to predict what the likelihood of something is after a particular event has occurred. But I absolutely think in the centre of it, there does need to be shared human decision making. And I think that the bit that will mean that the clinician remains central to resuscitation is that it's the clinician-patient relationship that's going to be critical for helping people to understand and to make informed decisions, because we're going to areas that won't be familiar to people across the population as a whole, but being able to explain it in a way that's meaningful so that shared decisions can be made about future care and treatment. So this is the final slide, which I think brings together the chain of survival 2050. So I hope in 25 or 24 years' time, when everyone looks back at my talk and think how good was the prediction that these four components will be there, that cardiac arrest prevention remains key, but we absolutely need to move it to the next level. Cardiac arrest detection is then key, turning the unwitnessed to the witnessed cardiac arrest, and then personalising the resuscitation attempt, and doing all of this in a way that delivers patient-centred care, so that you deliver the best outcomes for patients and the outcomes that matter to them and their family. And again, just pulling across at the bottom there, the things that I think that we need to do in order to ensure that we're able to get the most out of these technological opportunities. So there we go. That wraps up my vision for the chain of survival in 2050.
Oh, thank you very much indeed, Gavin. There's a huge amount to think about there, and you've got hearts and hand claps going up the screen from the audience out there. There's loads of questions coming in here. I think there's something around that patient-centered bit that you were talking about. Simon and Ingrid have both been asking about the DNA CPR, the patients that probably don't want or shouldn't have CPR because it's going to be futile or it's not their wish. And really interesting concept about whether you think that these technologies and talking about these technologies will also make people more proactive about talking about not doing CPR. Because if you're having a discussion with someone about the acceptability of technology, that's also partly talking about CPR and its treatment. So whether there might be a sort of knock on to improving the DNA CPR discussions, respect form and so forth, which I know you've been closely involved in developing the respect form, but whether that might improve those discussions.
Yeah, no, thanks, Ian. And I think it's a really good link between the two, is that I absolutely think that needs to be happening at a societal level, and resuscitation in a way is the very acute medical emergency. But as someone that works in intensive care, that there's also a lot of people, or we know from the literature, that people consume the majority of their health resource utilization in the last 6 months or 18 months of their life, and that's at the point that the quality of life is often the lowest. And I think that we're not having the societal debates at the moment about how much do we want to do for how long and what really matters to people, because I think the focus is, I think many times everything can be made better, and the reality is that each time there is something that enables a few years of extra life, that one will still reach the end point where that's not something that's going to carry on forever, and one would hope that through these the systems, and I guess the electronic health record screening piece for the detection of cardiac arrest could have a component within it that's not just the detection of cardiac arrest, but the alert to the starting to have a respect conversation.
Yeah, no, that's absolutely. I couldn't agree more with you about this. Needs to be something that's talked about a lot more, and there is questions also around the outcome that you're looking for. That we often say survival is the outcome, but are you going to be, putting all this technology in, increasing the survival, but actually creating survivors that have a significant disability? And how do you sort of put that into the equation of developing these technologies?
So survival with a favourable neurological outcome, when you talk to patients, as we've done through working out the core outcome set for cardiac arrest in other contexts, it's absolutely really highly valued, as is health-related quality of life and survival. But there are different balances that people put through them, which is for some people, survival, irrespective of the quality, is the thing that's most important to them. For other people, the quality of life is more important than simply the physical being. And I think this points again back towards more individualized conversations. In terms of why in trials do we tend to look at survival, the rationale for that is that survival and neurological outcome track reasonably closely, and they're also, with the current data systems, relatively easy to measure survival, whereas measuring neurological outcomes is more challenging because there aren't routine health records that you can turn to. And then when you start to lose people to follow up, you're starting to introduce bias potentially in the in the findings from the research. But when we have a future single patient record, then information like this is going to be more readily available. And I think just on the point of favourable neurological outcome, that a cerebral performance score of 1 or a modified ranking top performing can still leave quite significant functional impairment. And so those finer tools are key. But when people are having to trade off being alive with a bit of disability versus, clearly the goal is that, the goal is no one dies from a cardiac arrest unless by choice. And I guess that choice bit is around the not wanting to have a resuscitation attempt because they're reaching the end of their natural lives.
So other questions here, skipping around the topics. The recent RChem conference, there was quite a lot of emphasis on eCPR. Heart-lung machine in my young days was a room full of kit. It's now a handbag that you can carry on and put and then you don't need to do any CPR because you've got the patient on a machine that's doing the oxygenation and circulation for them. Really interesting question here from Jonathan saying, yeah, a lot of emphasis and technology and time spent on there. Do you think it would be better that if that time and effort and money got put back at the beginning of the chain rather than on those sort of interventional technologies?
So that's more of a generic question about eCPR versus the early parts of the chain of survival, or in the context of the talk.
Yeah, I think in the context of the talk, there's a lot of technology stuff. And do you think it's that bit that's important, or is it where are we going to get our most bang for
So
our buck,
yeah,
beginning
so I
or
think
the end?
yeah, no, definitely the beginning. But because if you can prevent a cardiac arrest from occurring, then that's almost invariably going to be the most clinically and cost-effective intervention. There was a really great study done in I think it was Denmark, where they have integrated electronic and social care records and able to demonstrate really eloquently that early bystander CPR and early defibrillation and early activation of the emergency services, those people were getting home. And the people in the later, stages of the chain of survival, because they've been in cardiac arrest for longer, that becomes more challenging, and those are the people that are often ending up having to go into nursing homes or rehabilitation. I think ECPR as a technology, has evolved a lot, and I moved through the slides very quickly. So there was a picture of the original ECPR machine, which, as you say, was the size of a hospital intensive care. And then there was also a picture of Dimitris Gambopoulos from the US with his backpack that he walks around with just in case he bumps into someone with CPR. So I think the technology is being miniaturized. I think that there's still the technology clearly works, and in a limitless resource setting where you're not limited, then having ECPR accessible up and down a country will undoubtedly save lives. But at the moment, I don't think a scale that would fit within the cost effectiveness or the public's willingness to pay. But I think it will find its niche as we move forward.
Yeah, I found the most interesting part of the ECPR experience was when they put the arterial line in. They then found just very small changes in where in hand position or Lucas position doing the CPR make a big difference
Yeah.
to the. So I was really interested in that and wondered whether, an early, now that we've all got ultrasound and ultrasound
Yeah.
skills, early arterial line actually might be the bit that comes out of that ECPR work
Yeah. Yeah.
around your personalization of physiology.
Yeah. No, absolutely.
There's a last question here, which we probably ought to time is running on, which is about the Warwick data set. And what are you going to be doing in the Warwick data set to actually capture some of this stuff as these new technologies start sort of getting put out into the wild there?
Yeah, so I think great question, and I will use the opportunity to thank the British Heart Foundation and Resuscitation Council UK who fund it, and all of the UK ambulance services who voluntarily contribute data to it, because it's been really key for us understanding what's happening in cardiac arrest in the UK, and the future state of that absolutely has to be that it is integrated as part of a health system, that we don't have a cardiac arrest registry that sits separately from an intensive care registry, that sits separately from the MINAP myocardial infarction, and the concept of an integrated patient record where all of that information can be pulled together into a single place has to be the future state. But it exists in order to study and evaluate the impact of health interventions, such as those described, and so will be a great evaluation platform in the future.
Yeah, excellent. Look, I think although there are more questions about paramedic skill fade, about whether you ought to have a doctor at scene, and whether that would improve outcomes, about discussion going on around disability, impact on disability, how we measure that, how we support people that have got disability following a cardiac arrest. Lots of really meaty stuff there. We could stay for another hour discussing all of that, but I think we need to wrap things up. Look, could I say, Gavin, thank you very much indeed. This is a really topical thing to be talking about, a really interesting vision of the of what the future might hold. I think you said in 2050 we have to review this, so it won't be my diary that I'm putting a note in for 2050, I don't think. But somehow we ought to have an AI agent that comes back in 2050 and just sees whether you were right about this stuff or not. On your screen, you can see the Trauma Care Charity UK Join Together QR code. Please scan that QR code and join Trauma Care to get more of this sort of stuff coming out. For Trauma Care members, your CPD certificates will be on their way. And I think that Tom is just going to flick on to the slide. If you're not a Trauma Care member, but you'd like a CPD certificate, they are available for £3. Please scan this QR code and you can get your CPD certificate. Or alternatively, scan the Join Today code and then you'll get your certificate for free and you'll be a Trauma Care member. Excellent. So thank you very much indeed. This video will be up on the Trauma Care YouTube channel in a few days' time. Just give Tom a little bit of time to do the to do the editing. If you've really enjoyed this and you don't want a CPD certificate, we'd still like you to give us the £3. You can donate to Trauma Care using this QR code here. That just enables us to do this stuff, to bring this sort of stuff to you, and to have these discussions. Gavin, I don't know if you can see the number of people in the chat that are saying thank you and putting really nice messages in there. We had 300 people on the call today, loads of messages of thanks coming in. Can I add my thanks to that? I know you've given up your evening to be here to talk to us. It's very much appreciated by the Trauma Care members and our guests that are on this video call. So thank you very much indeed, everybody. And we will see you in a month's time when we're talking about minor injuries in children with Dr. Fionn Davis. You've probably read her book if you work in an environment where you're treating minor injury in children. And she's also going to talk about when minor injury, the apparent minor injury, isn't all that minor, and how to spot non-accidental injury in children. So thank you very much indeed to everyone, and we'll close here. Thank you.